Hi, this is Brian Kim, and this is case number 7 in the best way to do cataract surgery series. This is a 1 to 2 plus dense lens. It's a medium pupil. I'm making my paracenteses incisions. Remember to make sure that the blade is parallel to the iris plane to create a nice shelf. And this way you'll have a nice self-sealing incision. I'm putting some intracameral lidocaine and epinephrine, and then I'm going to fill the eye with some viscoelastic. I go ahead and make my triplanar corneal incision. I make a vertical groove. I tunnel through the cornea and then dive in, creating this triplanar incision. I start my puncture capsular rhexis. I like to usually pull down and start subincisionally. However, this rhexis decided to go contra-incisionally. And so rather than fight the capsular rhexis, I decided to go with it. And I went ahead and grabbed the contralateral area of the flap and then created my counterclockwise flap. And as you can see, I'm grabbing repeatedly as I go. The point is if the rhexis wants to go in that direction, there's no reason to fight it. There's no reason to get a cystotome and recreate another cut. Go ahead and do the rhexis in which it wants me to go. Sometimes I'll have to even go clockwise. As long as you feel comfortable going clockwise or counterclockwise, and as long as you get an appropriately sized and well-centered rhexis, it's okay to do it this way as long as you feel confident in your technique. I go ahead and then burp some viscoelastic out of the anterior chamber and proceed with my Capsular Fornix Hydra Dissection. I place the cannula out to the contralateral equator and then rotate the tip downward and then create a nice fluid wave. I decompress the capsular bag, sweep to the right and then to the left. You can see I got some bubbles during the Hydra Dissection, but that's fine. Sweep to the left and then to the right. And as I continue to dial the lens here, you can see it starts to move fairly easily. I like to irrigate the surface of the eye before entering. Use a chopper to lift the corneal wound and then wiggle the phaco-tip in with irrigation off to reduce Descemet's trauma. Go ahead and remove the surface epinuclear material. I'm placing the chopper out to the equator, sliding it across, tilting the phaco-tip vertically. Go ahead and perform the double chop maneuver, crushing the lens in half, and then perform the cross chop maneuver, placing the chopper through the contralateral equator. I'm crushing the lens material between the chopper and the phaco-tip and intermittently pulsing ultrasonic energy and using vacuum to evacuate the lens material. I've already removed that one quadrant, and then I'm going to go ahead and crush this other quadrant, again utilizing mechanical fracturing forces, crushing the lens material between the chopper and phaco-tip, but it all begins with being able to place that chopper out to the equator. Again, I'm pushing down on the lens material. As I slide it out, I'm making sure I'm underneath the epinuclear material, which ensures that I'm inside the capsular bag when I do it. You saw that move again. I crushed that lens material there, and that is the third quadrant being emulsified. You can see the lens material is rather soft. And again, I'm crushing the lens material into bite-sized pieces. This is the last quadrant, placing the chopper out to the equator again, and then crushing the lens material. When the lens material is small enough, I'm emulsifying the lens pieces. This is a final little fragment. I'm crushing the lens material between the chopper and phaco-tip, and then using vacuum and ultrasonic energy to remove the lens material. And so this is the epinuclear material, which comes out very nicely. It collapses into the port. I always like to keep the chopper deep in the bag when I do this because sometimes the bag is still adherent to the epinuclear material. I'm irrigating with the cannula as I switch the phaco-tip to the INA tip to minimize any intraocular fluctuation in pressure to keep the chamber fairly stable. I start subincisionally with my INA. I get past the hardest part first, and I like to grab the anterior aspect of the cortex, not the part that's on the posterior aspect. So if I ever grab the part on the posterior aspect, I like to reflux it and let it go, and then try to come up right up to the anterior cortical material and try to peel it off. If you grab it from the anterior portion, you're able to clean the cortex off more easily and more cleanly. And so now I go ahead and switch to the polish mode and going underneath the anterior capsular surface. As you can see, the pupil is fairly small, so it's hard to see the capsular rhexis edge. I'm just sweeping. This polish setting along with the polymer tip really is very advantageous. I'm able to go at a fairly low vacuum and low aspiration rate, which reduces risk to the capsular bag. I'm able to polish the posterior capsule as well very confidently with very, very low risk of damaging the posterior capsule during these maneuvers. I'm very confident that that won't happen. I have not had that happen to me using this technique and with this polymer tip. I always use a BSS cannula to flush the capsular fornix subincisionally in areas where it's difficult to reach with the INA. And sometimes I'll see these little cortical wisps, which I call little dust bunnies, and you can see that right there. You want to make sure when you do this, you're activating irrigation, which is inflating the bag, and you're making sure that the cannula tip is definitely within the bag when you do this. I'm doing my fluid exchange, pulling the INA tip out, and then injecting viscoelastic as I go, and then I'm sweeping underneath the anterior capsular surface using the sweep, first on the left side and then on the right side. From this position, I go straight to injecting the single-piece acrylic intraocular lens. You can see the lens going in very nicely. As it's unfolding, I go straight to the INA. I like to rotate the lens 90 degrees as it's unfolding, and this ensures that the lens is completely within the capsular bag. I free up each haptic, and then I go underneath the lens and I dilate 90 degrees, and this sucks the lens into the capsular fornix, the capsular bag fornix actually. I'm irrigating out the viscoelastic from underneath the lens and in front of the posterior capsule, and then I center the lens and evacuate the remainder of the viscoelastic material. I don't like to collapse the anterior chamber when I come out, so again I like to use BSS to fill the anterior chamber as I withdraw the INA tip, and then I hydrate my incisions. So this is a fairly routine case for me, 1 to 2 plus nuclear sclerosis with a medium-sized pupil. I use mechanical fracturing forces to crush the lens material and bringing the lens out from the periphery into the central safe zone. I hope this was helpful to you, and thank you for your attention.